And good evening and welcome to everybody. Welcome to this week's Maternity Midwifery Hour. And I have to say, it's session 10 of series 17. I always get a little bit of buzz saying that. It seems a huge amount of series we've been through. My name's Sue Macdonald, and I'm the curator for the Maternity Midwifery Forums, festivals, and the Maternity Midwifery Hours. And it's my pleasure to be chairing this evening. And I've got two lovely speakers, two lovely midwives. Becky Lambert and Nicola Young. And because we always do this to them, we're going to ask if they can share a moment of their week. And I think you'll like them this week. So would Nicola like to start?
Thank you, Sue.
Welcome.
Thank you. My moment of the week is hearing that my dad got a date for his NHS hip operation, which is very exciting. If anybody is waiting for a date for surgery, they'll be able to appreciate that.
Whoop, whoop, whoop. I think so. And that's going to be probably the start of you being a bit of a chauffeur, I suspect, for a few days. I
Possibly.
suspect. Yeah, I think so. Fabulous. Thank you. Becky, you've got a moment too.
Yeah, my moment of the week is my 9-year-old son started playing rugby recently and he had his first match and they won it 20-4, which was a sterling win for his first time
Oh,
out.
fabulous. That is a lovely moment to share. Thank you so much. Well, we'll let our speakers have a little rest. And while we just settle into, I've got a little bit of news. I'm going to just remind people, because I know we've got 170 new participants joining us this evening, as well as our old friends. So welcome to you if you're new. You may or may not know that Maternity Hour started in the lockdown, first COVID-19 lockdown in 2020 in March. And we started this because, of course, because everyone had to be focused on clinical and dealing with COVID and adjusting services, we really felt we needed something for midwives, maternity support workers, for student midwives, and for educators, just as a contact and just to provide information and share what was going on in the service. And it was a scary time. I think anyone who was around there at that point will recall. But it was also very interesting because I think some of the midwives that came on, like the educationists, the managers and midwives providing care differently. Some of their explanations were absolutely fantastic and really very inspiring at that time. And I think at a time when we needed that sort of inspiration. And I'm coming to this because just to remind you also that everything's always recorded. I'm saying that just in case you have a power cut, or like I had the other day, someone cut an electrical cable and the whole power went. If it does, don't panic. Everything's recorded and you'll get links to this presentation this evening, as well as the podcast at 6 o'clock in the morning on Friday and also next week. You can always catch up, and that's my call to say that this is all looked after by Matflix. Everything's recorded, and you can access all of the back issues of the festivals and the maternity midwifery hours. This is really good if you're looking to do your revalidation, or you've got a project to do, or dissertation to do. It's a wonderful resource because I personally love to hear midwives and others talking about their research, their practice development, what they're doing face to face like this. It's really, it comes alive. Research is fantastic on paper, but that's kind of nice to do after you've heard someone talking about it. You sort of think, oh, I must find out about those figures and things. So do go and try into Matflix if you've got some time. And you might have your organization may have a subscription. And if not, try and get a subscription because it's really good and it means you can get free access. At the moment, if you get your personal access, it's a price of a cup of coffee or whatever on a week, so it's not too bad. But if you can get it free, it's even better. So that's it, and do share. And tonight you'll learn some new things as we try to make sure every week. And I personally find it very helpful to share. So you might want to share this with your colleagues, your fellow students, your fellow midwives, and just talk about the issues that are coming out because it helps you then kind of cement it in your brain and kind of it adds to your learning. Really helpful to do that. Now, I've just got I've got quite a bit of news actually. We've got, have a look at the resources tonight, because those I've tried to put as many references as we can get in there as possible. It was World Prematurity Day on the 17th, which was the day before yesterday. So big acknowledgement to the people caring for premature babies and their families. And I think it's been very heartwarming to see some of the stories of parents who've had premature babies. Sad for the babies that weren't able to make it. And we have to remember part of our work is to try and reduce prematurity, premature birth and labour as much as we can. So it's really important this week. And it's also, today is International Men's Day. I know we're midwives, but we do have men midwives and male students. And also there were two big things. The new Men's Health Strategy, which was launched today, published by the Department of Health and Social Care. That's on your list. It's about 50 odd pages, and I think it's been put in the news quite a bit, so people will know about it. Useful to have a sight of it so you know what's there. Also, I thought it was interesting that MP Marie Tidball highlighted that there's a 15.5% pay gap for men working normally with disabilities. And I thought that was quite interesting, because we need to know these things. And I have to make a shout out, having had Becky talking about her son doing the rugby. Of course, the big news also was the Scottish football team winning last night. I just saw edited highlights. I'm not a great sports person, but it was very exciting, and well done to them for getting through to the World Cup for next year. And also there's a lot in the media about maternity care, and I suspect a lot of people who are watching this are feeling, especially if they're in England or the UK, feeling a bit poleaxed about it, because there's a lot of bad news. And I think I've also put in the sort of newspaper features, so you can have a look and have a read. Now, when you're reading it, read it critically, I have to say, because I think some journalists have got some information that's useful to us, and we need to know what they're saying, because some of these reports are very scary for the women we're caring for and their families. And also it's very painful for us as midwives and students to read, but we need to look at it critically and look at the things that we haven't got right before, and look at how we communicate with women and families to get things better. And I would suggest have a look at Denise Tiran's blog, which gives the issues really well and really strongly, and I found it really helpful. So thank you, Denise, for that. And I'm probably talk a little bit more about that next week, so I have to be careful of my time. The other thing that I looked at was a blog from Claire Livingston at the RCM, and this was about Black maternal health, which is an issue that we still keep having to address. And it's a good blog to look at, because it brings the issues really sharply. Black women are twice as likely to be hospitalised with mental illness and twice as likely to die during pregnancy and childbirth than white women. And the recommendation is that transforming care means putting the voices and needs of Black women and their communities at the centre of decision making is critical. Culturally sensitive, trauma-informed, community-based social interventions are needed as a matter of urgency. And I think we need to almost put that in our brains, so it's there whenever we're caring for women, Black women, brown women, and white women, but especially Black women, because their needs we really need to address and start really reducing the poor outcomes. Absolutely. Now, this evening, we're going to be looking at diabetes and the lived midwifery experience of implementing genetic testing within the existing gestational diabetes care pathway to ensure real consistency and equity of access. And we're really delighted to welcome two fantastic midwives this evening. And because we've got two, the first is going to be Nicola Young, and I'm delighted to introduce Nicola, who's a midwife and a nurse, who is a project lead for a monogenic diabetes in the North East and Yorkshire Genomic Medicine Services. She's worked in several other regions. So this is, I think, the fourth region she's come to. So she's been in the South, the Southeast, and now the Northeast. And then we have Becky Lambert-Pitts, who's the project lead, Northeast and Yorkshire Genomic Medicine Service. She's currently working as a lead specialist midwife, and it's her first time working with genomics, but she's very passionate and excited about it, I think, which I think you'll see in her presentation. So welcome to Nicola and Becky. Nicola's going to start and then Becky's going to take over. But welcome. Thanks so much for coming. The screen is now yours.
Thanks, Sue. Thank you for the introduction. So we'd love to talk to you all this evening about glucokinase hyperglycemia. And we want to think about it in terms of rethinking gestational diabetes. So Becky and I are working with Northeast and Yorkshire Genomic Medicine Service on a midwifery-led project to raise awareness of monogenic diabetes amongst maternity diabetes teams, and specifically to focus on glucokinase hyperglycemia, which we'll refer to as GCK for short because it's quite a mouthful otherwise, within the existing gestational diabetes pathway. So monogenic diabetes is rare. It's a genetic form of diabetes caused by a single gene change in one of over 40 genes. And it's often referred to in the literature as maturity onset diabetes of the young, or MODY for short. So it accounts for 2% of all types of diabetes and 3.6% of diabetes diagnosed under the age of 30. It's estimated that around 77% of cases remain undiagnosed outside of the neonatal period. They're either undiagnosed or misdiagnosed with another form of diabetes, commonly type 1 diabetes or type 2 diabetes. And because of that, patients go through frequently a diagnostic odyssey, which is, a long and difficult journey that they and other rare disease patients will undertake before they finally receive an accurate diagnosis. Sometimes this can be years, sometimes decades. You can see in the image on the screen, on the map, that there is widespread regional variation, both in the number of cases diagnosed and referrals received. So what are some red flags that we might look for to suspect if you think your patient may possibly not have the type of diabetes they've been currently diagnosed with? So you'd be looking for young onset diabetes, particularly if it was diagnosed under the age of 25 years. A patient with diabetes whose body mass index is within normal range, so sort of unusually slim perhaps for a patient with type 2, for example, where there's a strong intergenerational family history of diabetes of any kind, particularly if diabetes is non-insulin dependent. You may also see that they have some congenital abnormalities as well, comorbidities, particularly if it was renal or reproductive tract abnormalities. And there may also be concurrent neonatal hyperglycemia and or fetal macrosomia in the history. So the main monogenic or MODY subtypes that you will see are glucokinase hyperglycemia, GCK, HNF1 alpha, HNF4 alpha, and HNF1 beta. There are many, many others, but those are the main ones. So, glucokinase hyperglycemia in pregnancy. So the incidence and prevalence of GCK is 1 in 1,000 in the general population, so relatively common. This genetic change results in a mildly raised fasting blood glucose level that will, of course, have been present from birth. And we often incidentally identify this during pregnancy through GTT mainly, because we're screening a cohort of otherwise healthy people who are essentially young, fit and healthy, and who may not have had much interaction with healthcare previously and just haven't had it diagnosed. And obviously we come along offering GTTs, testing their urine, etc., and we discover it incidentally. The normal HbA1c range for patients with GCK is, as you can see on the screen, quite wide, much higher than the normal range, 36 to 58 millimoles. So people with glucokinase hyperglycemia, they've got the same risk as everyone else in the general population of developing type 2 diabetes. It doesn't put them at more risk or less risk. And the mild hyperglycemia associated with GCK is not associated with an increase in either micro or macrovascular complications, such as we would all be familiar with patients who have type 1 or type 2 diabetes. Every baby of a parent who has GCK has a 50% or 1 in 2 chance of inheriting the same gene change. So you can see where that strong intergenerational family history comes in. Family testing for other family members is not required unless a family member has already been diagnosed as having another form of diabetes, so for example type 1 or type 2, or it's a relative who is planning a pregnancy. So we know that every year so many women are diagnosed with gestational diabetes, and the number is increasing year on year. What we also know is that around 1 to 2% of all women diagnosed with GDM will actually have glucokinase hyperglycemia. So therefore, we can say with certainty that GCK will be present within your maternity diabetes clinic. So you can see the testing criteria, which is laid out within the UK, within England, within the National Genomic Test Directory. So this outlines all genomic tests that are available for NHS patients in England for all conditions, and it standardises the criteria for testing. So it shouldn't be a postcode lottery. So the criteria is quite simple for glucokinase hyperglycemia: a current diagnosis of gestational diabetes, a fasting blood glucose level that's slightly higher, mildly hyperglycemic compared to normal, so between 5.5 to 8 millimoles per litre, and a normal BMI. So if the patient is white, a BMI of under 30, or if they're from an ethnic group where there's a higher prevalence of type 2 diabetes, slightly lower at 27. And then you can offer them the test as set out in the National Test Directory. So once it's diagnosed, what happens next? So as you can see from the image on the screen, which is courtesy of the Genomics education programme, it's showing us the autosomal dominant inheritance that we discussed. So where one parent is affected, every child has a 50% chance of inheriting the same gene change. So management of the pregnancy depends on whether the baby has inherited the same gene change as the mother. The reason we want to know is because the implication on birth weight. So as you can see from the graph, babies who haven't inherited the same gene change, which is in pink on the graph, can be approximately half a kilo heavier than babies who have inherited the same gene change as their mother. So we can find out whether the baby's inherited this through non-invasive testing. So non-invasive testing is available for 2 forms of monogenic diabetes currently: glucokinase hyperglycemia and HNF4 alpha. So the criteria to offer the non-invasive testing is again outlined in the National Genomic Test Directory, and you can see on the screen it would be again that the mother has been diagnosed with GCK. We can offer the test. There are a few situations where it wouldn't be appropriate. And if it is appropriate, you contact the specialist laboratory team at Exeter who do all the testing in England, and they will send you the relevant test pack, and you can just go ahead and do that. So the management of the pregnancy is guided by whether the baby has inherited the same gene change. So as you can see there, if the mother has GCK and her baby also has inherited the same gene change, there's no increased risk of macrosomia, and therefore the woman does not need treatment for her hyperglycemia. If the mother has GCK and her baby has not inherited the same gene change, which we know is a 50% chance, their baby is at an increased risk of macrosomia because obviously it's being exposed to hyperglycemia as with any other diabetic mother, and you would treat as appropriate. And finally, if the woman has GCK and the baby, we don't know the genotype, either because testing is not appropriate or the patient has declined it, or because she's diagnosed too late in the pregnancy, then you just have to treat as with an unknown genotype. So treatment would be individualized to the patient. And now I'll hand over to Becky, and she will tell us about her lived experience of implementing this testing at her trust.
Thank you very much, Nicola. Thank you for having us here this evening. So whilst Nicola's part of the presentation is very educational, mine is a little bit more me, because this is about implementing my lived experience doing this at Bradford, which we have nicknamed the Bradford Beacon, as we are shining light on Bradford, hopefully. So the first part is, the next slide, please, Nicola, is going to be a map of, a large map of the area right in the middle there, Bradford. So Bradford is the 5th largest local authority in England in terms of population size. It has a lot of similarities to Birmingham, Leeds, Manchester and Sheffield. Leeds is the closest to us. We have quite a similar population and similar numbers. The population of the inner city Bradford is a very ethnically diverse area. It is exceptionally deprived in some areas and has some of the worst health inequalities in England, including high rates of infant mortality, early mortality and long-term conditions. Over 50% of our pregnant population are overweight or obese, so we do have a lot of ladies who have very high BMIs in Bradford. Which, given what Nicola has just gone through the testing criteria, that is one of the areas that we fall down in for testing. And in Bradford, we have around 5,500 babies born every year, give or take a few, which is similar to some of the units in our area. And a massive amount of that 5,500, a massive amount of those patients are GDM. We're looking at about 1/5 of our population are GDM patients, which leads us on nicely to getting started with testing. So when anything is introduced as a new procedure, a new policy, getting started is the hardest bit. So I approached this from a QI kind of standpoint, if you like. So I started it as a quality improvement project with our OMS, which is our outstanding maternity services team, who have been endlessly helpful throughout this. So first point is discussion and communication with your MDT. So you need to be having conversations, and I started by having conversations with our head of midwifery, maternity matrons, our clinical and deputy clinical director, my diabetes MDT, which at Bradford is quite a large MDT. I think there's about 15 of us, antenatal clinic manager, and the midwives who work on the floor in antenatal clinic. I wanted them to be on the same page as me. Why are we doing this testing? What are the benefits? Who are we testing? And why are we testing? What are the benefits, rather? And who are we testing? So keeping that communication open with your team, that is the best point of getting started. So amending existing diabetes and pregnancy trust guidelines and developing a SOP. Now, this seemed daunting to me because our diabetes guideline, like most trusts, it is exceptionally large. It is a little bit like War and Peace. So it does seem a daunting thing to start. However, because there's no NICE or RCOG guidance at the minute with regards to GCK, we do have the Diabetes Genes website, which is where we have guidance for this. So that's a guidance in starting your change of guidance. It is a paragraph that I ended up putting into our guidelines, so it's not a huge, a huge portion of your guideline. And the SOP I developed alongside our, between me and Nicola and the wider team for GCK and our MDT, and it's a 1-page SOP. So a doable amount of guideline and SOP. So when I started discussions and communication with the wider team, I missed out some very important people. So the pathology lab and the post-room team are really important to get on board. So the pathology lab, obviously, we're taking samples, we're sending samples. It didn't even enter my head that I would need to speak to these people in the first instance. So now made friends with the pathology lab. At Bradford, we decided that it would be easier for the samples to go directly from me and straight out from me down to Exeter, so it doesn't go to our lab. Now, this will be different for different locations. Everyone will have their own way of doing it, but it's important to have that conversation to find out what's best. Post-room team, logistically, it needs to get from the patient through me and out of our hospital. Our post-room have done it as they do it as a recorded delivery for me. They've provided the parcel, the packaging, and you do need to follow some quite strict guidance, which is available on the Royal Mail website. And I believe it's guidance 650 for packaging of samples. So those two people were really important to speak to. So developing standardised review for OGTT and blood results. So at my trust, we have a wonderful dashboard, which allows us to have the, just bear with me 1 second, because I'm having a little.
It sounds like Becky's Wi-Fi's gone slightly astray, but hopefully she's coming back to us.
Sorry, I'm back. I was having a little dip there. The OGTT results. So we have a dashboard that our business analyst team has put together, and that tells me every day how many people are raised, and what those results are. I'm currently working with them to amend it a little bit further so that the BMI results and the patient's ethnic background are on there. Of course, I have been going in individually to records to look at these other details, so that just takes a little bit more time. So we're developing a different way of doing that. So review and analysis of GDM cohort. So I looked back at 6 months worth of data to see what the numbers were going to be retrospectively. And as I say, GDM patients make up 1/5 of our birthing population at Bradford. So I've looked back at those dates, at those figures, and they should be coming up in the next. Oh, so sorry. GDM, as we said, Nicola said, is on the rise. So back in 2020 at Bradford, we had 444 ladies diagnosed GDM. And in 2025, we are currently on track, when we get to the end of March, to be around about 1,000. So that number is just on the up massively. We do have a higher proportion of South Asian ladies at about 60%, lower numbers of Black ladies at 6.7 and white women at 26.7. And as previously said, we do have a high proportion of deprivation, about 53%. So the numbers that I looked back on, which should hopefully be on the next slide, I've got those confused. Next one, please, Nick, that's it. 472 women were diagnosed with GDM over a 6-month period from July to December 2024. 16 of those women met the eligibility criteria for GCK testing, and that represented 3.3% of the GDM cohort within that 6-month period. So that's the numbers that we were looking at for GCK testing. So challenges. So first stop is keeping the awareness amongst your wider MDT. The amount of times that I stop consultants within our MDT in the corridor just to remind them that I'm doing this, or just to remind them that I've just tested a patient, or keeping it fresh in the mind. New things take time to embed. So just keeping that conversation going and making sure that your full team know why you're doing this. And like I've said, who are we testing? Why are we testing them? So specific testing issues within trusts. So initially, I thought that my specific testing issues would be with logistics, postage, getting the samples out of the building, the time for doing the checks and the auditing, and staff involvement and staff getting on board. I was exceptionally wrong. My team at Bradford have been amazing, to use the word exceptional again. They have been exceptional in accepting this. My main area of issue has been, and it is an issue at Bradford, patients accepting care and wanting to access care. So I've had quite a large number of ladies, unfortunately, who've declined testing for many reasons. But yeah, patient engagement has been one of the most difficult. So a lot of ladies have not wanted any further testing, and that was the bottom line. They just didn't want any further blood tests. Some people have declined because they just didn't like the idea of genetic testing. I'm sure some people have maybe not fully understood, and when we've tried to delve deeper, they've just not been interested. So there has been a number of problems for me, which is just something that, you have to have some resilience for and get used to, really. So those are the biggest challenges that we faced, which leads me nicely on to keeping the momentum going and resilience. So if you don't have great resilience, this will definitely develop your resilience skills, as it has done with me. So we have to remember, this is not about the amount of women that we get as a positive result, which has been drummed into me and I now feel is settled within me. It isn't about the number of women that we're getting positive. It's about the number of women that we are testing, and it's the equality of that test and the availability of that test across the board for all eligible patients. So my resilience has gone up tenfold. And when we put this presentation together, I'd only tested 2 patients. However, I'm now at a whopping 5. I've still not had a positive, but my resilience is ongoing and getting stronger. So we will just keep it going and see where we get to. Sustainability wise, it is exceptionally important. I love that word this evening, exceptionally important, that you are keeping, that you're not a single point of failure. So I was, or currently am to a degree, still a single point of failure. It only takes annual leave or illness for some scaffolding around this to fall down. So I am very keen on training other members of my team. So I have 2 wonderful midwives that work alongside me, and I'm going to be training them in consenting ladies for the test, and making sure that there is somebody there at all times that can complete the consent, can do the testing, and can get it out of the building down to Exeter. So yeah, key to have a number of team members alongside. And then audit, with it being a QI project, that's the way that I approached it. I'm constantly auditing. I'm constantly looking at who we're testing, how many we're testing. If we're not testing them, why aren't we? I'm starting a bigger piece of work soon on ladies who decide against the test, to look into reasons for declining the test. So auditing all the time, keeping it moving forward. So audit is key. And then sources of support. So there are a good few sources of support. So we have the 1 in 6 billion podcast, which is a wonderful listen, and that's available on all podcast platforms. We have our regional community of practice support group. So that is a safe space for us to get together regionally, DSMs, any members of the MDT who want to, come to that can. And it's a troubleshooting area where we can discuss, our wins. And we do have definite fails that we discuss as well, and fall down areas, but we're keeping that, it's about keeping that momentum going and supporting each other through it. The Diabetes Genes website is an amazing resource for all things GCK and all things, diabetes genes. And we also have the North Eastern Yorkshire digital GMS digital toolkit, which we've been working on through this project, to enable people to have a toolkit of resources to go to, so that they've got a starting point, they can cherry pick information and then make their own guidance and SOPs and things like that. And then finally, it is about, the take-home messages. So remembering your red flags. This can appear in family history, test results, or scans. As Nicola said, we are within maternity testing and otherwise mostly healthy population. So it can be found incidentally, but it also can be found in family history. So make sure that you're assessing family history and looking at family history properly. Early risk assessment allows timely testing. So Nicola did mention when ladies get diagnosed later. So the sooner that we can diagnose these ladies in pregnancy, the better. Knowing your own local clinical pathways and discussing within your MDT. So like I've said a couple of times, keeping that conversation going with your MDT, and knowing your own pathways and how this will fit into your own pathways. And last but not least, when in doubt, ask. All those resources that I've mentioned are available, and I may live to regret saying, but I always say I'm always contactable. My email address is out there, so I'm happy, and I'm sure Nicola will be. And if she's not, I'm nominating you for any questions or queries. And these are the where to go next. So the 1 in 6 billion podcast, as I've mentioned, and the Diabetes Gene website QR codes are available for easy access. Thank you very much.
The 1 in 6 billion podcast is a wonderful podcast hosted by Professor Andrew Hattersley and Professor Maggie Shepherd of Exeter. and they are some of the foremost experts globally in monogenic diabetes. And in particular, series 3, episodes 5, 6, and 7 focus on GCK. But all of the episodes are excellent. Some are a bit of a tearjerker, others are funny. They cover all the different types of diabetes, lots of really interesting research and latest developments, and they're definitely worth a listen. And as Becky said, there's the Diabetes Genes website. That's what it looks like. There's all the up-to-date information on there, including management guidelines for pregnancy, because as Becky said, currently there's no NICE guidance or RCOG guidance specifically for monogenic diabetes, let alone in pregnancy. So the Diabetes Genes website provides the accepted national guidance in lieu of it being NICE or RCOG.
Thank you very much. Fantastic. And now I'll just remind our audience, if you've got any questions for Becky or Nicola, just send them in the chat box and they'll come through to me, which is why I'm looking over here to my other screen to get the questions to Becky and Nicola. One of the questions I wanted to ask is, how simple is the diabetes genes website to navigate, and also is there sort of some learning materials that are very simple for people who might find genetic bits a bit stressful? And I say this because I know the first time years ago when I was introduced to genetics and all those little diagrams and things, it took me a lot of time to get my brain round it and think about what it actually meant in practice. So I just wonder how it's set up,
that's
Nicola.
a good question. So the Diabetes Genes website is a public-facing website, so it's for professionals and patients.
Oh, wow.
So it's kind of pitched in a sort of, I don't know, interim hybrid sort of level, I guess. It's not very sort of genetic-y, biologically sort of heavy, I would say. So it is accessible. And you can see on the the screenshot there that you can look at what type of diabetes, and it explains about each of the main subtypes. Also explains about neonatal diabetes, rarer types, the different tests. You can also find the test form, because obviously you're not going to be able to just order this test on your trust test directory as you would for anything else. You would need to download the test form from this website and complete that, and it asks quite a lot of background information in order for the clinical scientist to be able to process the test appropriately. So they will ask for things like obviously the patient's demographics and their BMI, and are they pregnant, and what type of diabetes they've got, and do any family members have diabetes, and all these kind of things. It's the same test form for all the different subtypes of diabetes. You don't need to fill in all of the test form if you're only suspecting your patient has this one very straightforward subtype, GCK, because it can be quite off-putting when you look at the form, and it's quite long, and it asks for a lot of information in terms of type 1 blood test results, GAD results, C-peptide, zinc transporter, all that kind of thing. And if you're thinking, well, my patient's got GDM and we haven't done any of that, you don't need to fill that part in.
Now, I remember you had the little map of England. So are you saying that wherever you are in England, even if you haven't got a project like that you're part of going, you can make a request in for a particular test?
Yeah, so all genetic tests available to NHS patients in England can be found on, if you just Google National Genomic Test Directory, and you'll see all genetic tests, whether it's for cardiomyopathy or anything. There are so many inherited conditions, aren't there? Everything in the world sort of on there, and it will tell you what the eligibility criteria is for each of those tests, because obviously different tests the criteria will change over time. So it is always worth just checking on there to see if there's been a change. But that will set out the eligibility criteria, and they will direct you in that test directory to the Diabetes Genes website to obtain the correct test form, the consent form. Or you can get it directly from the Diabetes Genes website and download it, complete it, and send a copy off with the sample, and then email a copy to the lab as well, so they know to expect the sample.
Yeah, I like Becky's description of her work with the post room, because this is the sort of thing that with these sort of projects, that is almost, this happens invisibly, doesn't it? But in this sort of quality improvement project, you need to know the root of everything, from the patient, from the woman, all through the results, through everything. And I really enjoyed that bit, Becky, and thank you for that. I did wonder, because you were saying about some women refusing the test, and I wondered when you said that, I mean, how do you go about making sure women understand? Do you always make sure you have a translating service for that particular consent? I might be doing very obvious, but it's just to clarify for people.
No, that's fine. So yeah, we would always have an appropriate interpreter available, and even for so I tend to see these ladies when they come for the first appointment after being diagnosed. So they would always have an interpreter for that appointment, and then if I can tag that conversation on, then I will. But if I can't and it has to be a separate, then we'd always have interpreting services. But we were discussing this earlier today, myself, Nicola, and Denise, our project lead, about varying reasons, and there is varying reasons, and there will be varying reasons for declining testing in different localities, and that's a big piece of work that I want to look into to find out, is it about understanding, is it, where does the problem lie? So that's my next piece of work, to look at that.
And that sounds quite a big task, actually, with the auditing, and really useful to track down, because as soon as you were saying that, my mind was going and thinking, well, I wonder why would you be refusing a test? Because in a lot of situations, women are very keen to have the tests, any tests, to sort of almost enforce the fact they're going, all is going to be fine, all is going to be normal, and they're going to know exactly what they're dealing with. So I was very interested in that aspect of it.
Yeah, we do have problems, not just with this, even just with having people coming in for a glucose tolerance test, that they decline it, and we did a big QI piece of work a while ago on that, and we're still working on that. Because there's just so many reasons as to why people decline.
I hoped you were going to give me a little result there, Becky.
No, it's an ongoing piece of work, really. And we've been working on it because we've had a lot of changes at Bradford within the diabetes service as well. So it's just getting to the bottom of those reasons and trying to embed anything we can into practice to improve those DNA rates and decline rates, really.
Yeah, because I mean, some of the statistics, like 77% of cases being undiagnosed, it's quite stark, isn't it? I mean, when you look at, especially when you had the little tables of all the results going upwards, everything's going up and getting worse. It's quite thought-provoking, actually, to how we can deal with it.
Yeah, absolutely. It is. There's just so many different areas to deal with. It's kind of multifaceted, isn't it, almost? So yeah, I'm doing as many QI projects at one time as I can to get to the bottom of it.
Gonna list them out now. Wonderful. Okay. And the other query I had, you said that I was interested in this, the baby's not affected by GCK were likely to be, the mother 500 grams heavier. So presumably those babies are at greater risk of things like shoulder dystocia. Oh, fab. No, that's really, that's good as well. I think something floated through my brain there, it's just wafted away. Sorry. The sustainability, because that's another thing with any project, isn't it? that you go on a week's holiday sometimes, and that can have an impact on the project. But the way you would describe about other people being involved, I think was fantastic for a sustainability aspect, because this is a huge thing for any project.
Yeah, absolutely. And I've learned, Nicola's laughed at me before because where I go, my laptop goes. It's been abroad with me, it's been to Wales with me and my family, and it's I didn't have that that backup, if you like, because nobody else, when I initially started doing this, was doing what I was doing within my team. So I quickly realized you can't my laptop doesn't need annual leave. So I've now started leaving that at home, and very keen to get the rest of the team on board so that there's not a single point of failure, and so that the testing and delivery of results even remains consistent and stable even when I'm not there. So yeah, it's been a piece of work, but we're getting there.
Yeah, well, it sounds to me like it's a piece of work that's just spreading and spreading and spreading, which is great. As you get you're getting questions as you're getting answers, which is a lovely result for you, and well deserved. And Nicola, okay, I'll ask the same sort of thing. I just have to apologize to people online, because I know there are some problems tonight. But we'll make sure this is all packaged up so it's all perfect for you if you're one of the people that's affected. So Nicola Young, to you. You've obviously you love this whole area, because this is not your first experience. So
No.
what's the best bit about your role?
I guess the thing I enjoy about this seconded role is that it enables me to have a wider view than just the very narrow aspect of midwifery that forms the other part of my job, which is just being a regular normal midwife. And it's really, we can all get in a silo, and you get used to what you're doing, and your focus is only on that particular aspect of midwifery that you're working in. And it's really nice to be exposed to the rest of the landscape out there, both in ongoing national work that's going on with GCK, apart from the regional project we're working on. There is an interest across the country. Momentum's been building over a number of years now. I started off doing this project with in the southeast Genomic region, and then moved and did the same project in the east of England Genomic region, and then now doing this in northeastern Yorkshire. So clinicians tend to be interested. Mostly people are intrigued by monogenic diabetes, as I was when I first heard about it. It is very interesting. I think so. Becky and I think so anyway. And it's nice to see that other aspects of midwifery.
Fabulous. Well, I think it's been very interesting. It's been fascinating, actually, and thank you so much to Becky and Nikki or Nicola, sorry, if I've shortened your name without meaning to, sorry. And thank you so much for coming and sharing your experience and this information. I think the audience will note the last slide or two, and remember that you'll get a recording for this, and you can relook at it and get the links. And if you have any problems, just get in touch with Nicola or Becky, and they'll be very happy, I think, to provide any further information. I also want to say a big thank you to Angelo, who is our producer, who's making sure this is all going to be nicely recorded and available after this evening. And also thank you to Paul, who's managing the live stream and the Facebook bit of it. Now, next week, just to confuse everybody, we're in Edinburgh, because it's the Maternity Midwifery Festival in Edinburgh next week on Tuesday. But we will be doing Wednesday. And I'm going to make sure I've got a computer, because I'll be doing the Wednesday evening in Edinburgh, which will be great fun. And we're looking at domestic violence, which isn't so fun, but it's a really important area. Domestic violence and abuse, supporting women, supporting practitioners. And this is the week of the International Day for the Elimination of Violence Against Women. And we're looking at domestic violence in the context of maternity services for all the reasons that we know as midwives, and also to think about us as midwives and healthcare workers. And we're joined by Caroline Bull, who's a specialist midwife for substance misuse and domestic abuse, and Judith Rees, CEO of For the Baby's Sake charity. So I just want to say a bit of an apology for those of you who have problems with the live stream, but we'll make sure that you get the recording beautifully as always. And actually I'm just going to do a quick thing about my favorite, as you know, the New Ways November Action for Happiness calendar. I have to say this now. Today's little task, there's a little task every day for you. And today's was broaden your perspective, read a different paper, magazine or site, or listen to the lovely Becky and Nicola, of course. But tomorrow, because we need to look forward to tomorrow, make a meal using a recipe ingredient you've not tried before. So that's a little thing for tomorrow morning. So in finishing, huge thank you to everyone for coming along. And thank you again to Becky and Nicola. We'll see you next week. And in the meantime, take care.